for inviting me to speak today. Dr. Laxmi, Mehta, and I are very happy to be here today with you. For us, it's 1:30, and so it's not hard for us to be here, but thank you all for joining us today. What I'd like to, can you all see my screen?
Yes, we can see your screen.
Okay, good. Thank you so much. So
Okay.
I was asked to speak about the connection of COVID-19 and cardiovascular disease. I know there are a lot of issues for women and COVID-19, and I think some of our panelists and speakers will address those issues. But for my talk, I will just talk about specifically cardiovascular disease and COVID-19. This is a picture of my colleagues at Rush Heart Center for Women. As you can see, we're a very diverse group of women and men that take care of patients in Chicago area. And we've seen a fair share of our COVID patients. So we're dealing with COVID-19 in a big way at Rush University Medical Center because the hospital was built for COVID-19 and pandemic. So we are taking care of over several thousands of patients already. We usually have over 200 patients at one time in our hospital system. So we do take care of a lot of patients. Dr. Laxmi, Mehta, and I thought of this review paper, and we wrote a scientific statement about South Asians and the risk of cardiovascular disease in the United States. But as you know, cardiovascular disease affects a lot of South Asians throughout the world. And the South Asians that we're speaking about are definitely the ones in Pakistan. So I'm going to concentrate on the Pakistan cardiovascular disease and COVID-19. As you know, there are a lot of comorbidities that affect cardiovascular disease and the risk of COVID-19 mortality. So we're going to speak about that. This is a global disease. It's a global pandemic. And as you can see, the dark red are the ones that are affected the most. It started in China and then spread to Europe. So Italy has been very much affected. And I'm going to compare the Pakistan people to the Italian people, and you can see the differences. But America, the United States, has the most people affected by COVID. And since it's a big population, we are seeing a lot of that. So COVID-19 intersects with cardiovascular disease, and we're going to specifically concentrate on women and sex differences in this problem. This is an interesting website that collects sex disaggregated data. So it's a global health 50-50, and the website is here. I just updated this, and as you can see, Thailand has the highest male to female ratio in terms of death mortality ratio. But you have to be careful in interpreting this data because this is a very small number of deaths. So I don't want to make it seem like there are so many more men dying of COVID-19, but I want to concentrate on the two countries here in the bottom. Interestingly, most countries have a higher male to female death ratio, but not the case in India and Pakistan. And I don't have the India numbers here because they don't have the complete sex disaggregated data yet, but Pakistan has a male to female ratio that is less than 1. So I want to make sure that people understand what this means. In terms of deaths, there have been about 727 deaths as of the collection of this data, compared to 27,000 deaths in Italy. And if you look at the deaths in terms of percent males and percent females, there are definitely a lot more men who are dying from COVID-19 compared to women. But if you look at the deaths in confirmed ratios among the men, the there's a 2.1% in Pakistan versus 2.3 in women. So there is a more women who get COVID-19 who die from it than men who get COVID-19 who die from it. And that's why there's a ratio of less than 1. But if you look at the Italian data, you can see that there's a much higher death mortality rate in Italy compared to Pakistan. And it's much higher in men than in women. And that's why they have an almost 2-to-1 ratio of men dying from COVID-19 to women dying from COVID-19. And this is a chart specifically from Italy and from Pakistan. As you can see, in Italy, there is a skewed ratio of men and women. So the men are in the blue and the women are in the orange. There are a lot more older people getting COVID-19. And in terms of deaths over here to the right, there are more men dying of COVID-19 than women, even though more women get COVID-19. In Pakistan, it's actually very different. You see the ratio, the distribution is more of a bell-shaped curve. So there are a lot of men and women, a lot more men than women having COVID-19 cases, but the deaths go up as the men get older. So there are definitely a lot more men dying of COVID-19, but when women get COVID-19, their risk is slightly higher than the men. So very interesting. So there are sex differences in mortality from COVID-19. And Dr. Sharma and Dr. Mikos and I wrote this paper that was just published. So we're seeing this mortality case ratio that is higher for men in most countries. And we attributed this to maybe the higher risk of ischemic heart disease in men. The lifestyles are different in men, especially in Italy. They have more smoking, they have more alcohol use in the men, but women have a higher immune response than men. So that might be playing a role as well. And we're going to talk about that. We're going to talk mostly about ACE2 receptors because that is the way COVID-19, the coronavirus gets into the cells. This is a recent study that showed that there are sex differences in the response, in the immune response to COVID-19 in terms of IgG antibody level. So even though there were more, I'm just going to show you in terms of the IgG response. You can see here that in terms of men to female ratio, it's similar if you have mild case or in general, but if you have a severe case of COVID-19, the women mount a higher IgG response compared to the males. And they're about the same in the recovered patients. So in the severe cases of COVID-19, the women have a higher immune response. So that's one difference that we're seeing. In terms of COVID-19 and cardiovascular disease, there is a higher risk of heart failure and acute cardiovascular injury in the patients who die of COVID-19. So cardiovascular disease is definitely a risk factor in when people get COVID-19. So I'm going to talk mostly about this coronavirus and the interaction of it with ACE2 receptors. As you can see here, this is the virus. And in order for the virus to get into the cell, to kill the cell and to replicate, is by using the ACE2 receptor. So ACE2 receptors are very important in the COVID-19 disease. And another sex difference that we can see is in the ACE2 expression in the human organs. As you can see here, the small intestine have the most ACE2 expression in the organs, followed only by the testes, second only to the intestines. So the testicles definitely have a higher ACE2 receptors than the ovary and the fallopian tube and the vaginal cells. So very interesting. here is the heart muscle. So they definitely have ACE2 receptors. And the lungs are way down here, but it seems to be affecting the lung tissue in a very big way, and that remains to be explained. So there was a question of whether ACE inhibitors and ACE2 and ACE angiotensin receptor blockers and other renin-angiotensin-aldosterone system blockers would increase the mortality or the morbidity of patients who are on ACE inhibitors. And there was a worry that our patients, and they were calling us to see if I somehow lost my let me get back to my Zoom. There was a worry among our patients whether they would not fare as well if they were on ACE or ARBs. And so until some of the studies reported that there was no risk, we didn't really know the answer. I think that people are much 9 hospitals in Hubei province, which is where Wuhan is. And just to shortcut, I wanted to show you that there were 188 patients among the patients who were studied, in the 3,000 patients who were studied. There were 188 patients who were in ACE or ARB, and there were 522 who were not on ACE or ARBs. And so they did a propensity score match study. And what they found was in the adjusted hazard ratio, there were definitely less deaths in the patients who were on ACE or ARBs. So this was very comforting for our patients who were on ACE or ARBs. Another study that was just done in New York, that was done by Dr. Harmony Reynolds and Dr. Hockman from NYU, looked at their population, and they looked at 12,000 patients who tested for COVID. And among their patients who had hypertension, they found no substantial increase in getting COVID or getting worse outcomes from being on the ACE or ARBs compared to the other classes of antihypertensive drugs. Another study that looked at ACE and ARBs in hypertensive patients showed that there was no significant difference among the women and men who got COVID, who had hypertension. But what they did find was that there was significantly lower concentrations of hsCRP and procalcitonin in the patients who were on ACE or ARBs compared to those who were not. Even though there was no significant difference in the critical patients or mortality, it was interesting to find that the ACE and ARBs decreased inflammation in these patients. So very interesting. This is just to show you that the ACE2 receptors that I was talking about for the virus to get into the cell is just one kind of ACE2 receptors. There seems to be soluble ACE2 receptors that are also present in the plasma that do bind to the coronavirus. And these will just be cleared away by the immune system. So if you have a lot of IgG that can clear this ACE2 receptors binding to the coronavirus, it may be the reason why women are getting less mortality than the men. So interestingly, at the beginning of the COVID pandemic, all the major cardiovascular societies recommended not stopping the ACE or ARBs in patients with other RAS medications in patients who were taking them. So they made the right call by telling patients not to stop those ACE inhibitors and ARBs if they had hypertension. another interesting study that literally just came out today, and I wanted to share you, was the study that looked at the characteristics of outcomes of patients hospitalized with COVID-19. And what they found was that definitely cardiac disease is a risk factor for mortality in patients who have COVID. They found that patients with cardiovascular disease had an increased risk of death. As you can see in this red, this is patients with cardiac disease. They have more deaths. They also have more ARDS, which is acute respiratory distress syndrome, acute venous thromboembolic disease, arterial thromboembolic disease, and more septic shock. So very interesting. They found that patients who had cardiac troponin that was elevated, that was a prognostic biomarker in patients who were admitted for COVID-19. So we are learning. I think there are more questions than answers, but we are starting to get some answers. And with the rapidity of the publications of so many studies on COVID-19, if you can believe it, since December 2019 and until today, there have been 12,000 papers published in PubMed regarding COVID-19. So very interesting. I wrote this op-ed because what we were finding is that all of a sudden, with the COVID pandemic, there were less people presenting with heart attacks and strokes. And we were seeing that people were not coming into the hospital. And this is worrisome for us because we know that heart disease and strokes have not gone away. We just are not seeing those patients present to the hospital. So even though COVID-19, I got this from the AHA, that has been trying to tell people, don't worry about coming into the hospital, because if you're having a stroke or heart attack, you need to come into the hospital to get care, because you could die from strokes and heart attacks. So even though COVID-19 has changed a lot, the bottom line of strokes and heart attacks have not changed. And they are pleading people to call 911 if they have these symptoms, because it's still the best chance to live. So thank you so much for your attention. And I would like to end here. Thank you.
Thank you, Dr. Volgman. This talk was excellent and very relevant to the current pandemic. We would like to tell all the participants that the questions will be right at the end. So we would move on to the next speaker, Dr. Anita Sadeghpour. She would talk about stigma prevention and psychological perspectives. So over to you, Dr. Sadeghpour.
Hi, everyone. Can you hear me?
Yes, Dr. Anita.
Yeah. So hi, everyone. It's a pleasure to be part of this great webinar. Thanks for invitation. I just want to make a correction that I'm Professor of Cardiology from Rajai Heart Center. This is my first affiliation from Iran, Tehran, and also I'm now in Duke. I'm going to talk about the definition and etiology of stigma in COVID-19 pandemic, the impact of stigma in people and communities, and also people who are at risk for stigmatization, negative impacts of COVID-19 on women, how we can prevent and reduce the stigma. Stigma and discrimination is common in disease outbreaks, even it can be more dangerous than the disease itself. And in COVID-19 pandemic, stigmatization means people are labeled, stereotyped, or discriminated because some other people believe those population or even nationality are greater risk for spreading COVID-19, even though not everyone in that population is specifically at risk for this disease. So COVID-19 pandemic is stressful. We know it's stressful for all people around the world. But why the COVID-19 causing stigma? COVID-19 pandemic is new disease with many unknowns and misinformations, which can create fear and even blaming anyone who have been in contact with the virus or people from a certain geographic region. Stigmatized people may suffer psychologically and economically, and the stigma hurts everyone and may result in more severe health problems and difficulties in controlling the outbreak. These people may be subjected for social rejection, facing difficulties in accessing education, housing, finding jobs, and even may be targets for verbal, emotional, and physical abuse. So people will try to hide the illness or even choose not to be tested to avoid being labeled as corona-positive patients. People who are at risk for stigmatization are persons of Asian descent, people returning from travel, healthcare workers, emergency responders, people with disease and their family and friends, people released from quarantine. The COVID-19 pandemic affects everyone, although it has more negative impact in women. Female healthcare workers, unfortunately, they face a double burden, one at work and one at home. In the workplace, women are less paid and less likely to be in management position. They also are at risk for stigmatization due to caring for COVID-19 patients. How to stop or prevent or reduce social stigma? Indeed, everyone can help to stop by knowing the facts and sharing them in the community. Everyone should be cautious about the negative impact of certain words and images that are shared. The words matters. The words are important. Do not attach the ethnicity or location to the virus. It is not Chinese, Wuhan, or Asian virus. It is coronavirus disease 2019. That's why it is called COVID-19. We have to say people who have COVID-19, not the people or COVID-19 cases or COVID-19 suspects. And more importantly, maintain privacy and confidentiality of those who are seeking for the healthcare. Governments, communities, public health, officials, and media have an important role in preventing and stopping stigma. By spreading the facts about the transmission, treatment, and prevention of COVID-19, they can amplify the voices, engage with a stigmatized group in person and through social media and news. They can show compassion and support for individuals and communities. And what we can do as individuals, by speaking up, if we hear or see a stigmatization or misinformation, show compassion and support for individuals and communities more closely impacted, by avoiding stigmatizing people who are in quarantine. We can thank healthcare workers, responders, and others who are caring for people with COVID-19, and even calling them COVID-19 heroes. Share positive messages in social media. And we know that research has shown that 70% of workers in the health and social sector are women, and they need the appreciation and support. Stigma can damage the mental health and well-being of a stigmatized group. These are the ways to cope with the stress. Take a break from watching, reading, listening to the pandemic news. Those are going to be overwhelmed and upsetting. By taking care of your body, having a stretch, meditation, and eating well, sleeping well, exercise, and even doing something that is enjoyable. We can be creative even at work. These are images that my colleagues shared at the society's scientific group and social media. by finding something which is easy to have additional protection, such as these protection that is easily made, and it has been shown that can be effective when there is a shortage of the PPE. Although everyone has to follow the standard personal protective equipment, adding these protective shield can be very helpful and even reduce the exposure to the virus. So in summary, in COVID-19 pandemic, social stigma is common. Sometimes stigma of COVID-19 is more dangerous than the disease. Everyone can prevent social stigma by choosing appropriate words and spreading valid information. Thank you.
Thank you, Dr. Sadeghpour. This was a very relevant talk, especially for mental health awareness. We would now like to invite Dr. Mehta for her presentation on COVID-19 and healthcare burnout.
Thank you.
Thank you. Can you see my screen?
Yes, Dr. Laxmi.
Wonderful. Thank you for inviting me to speak on behalf of the American Heart Association, and we're pleased with our partnership with the Pakistani Cardiac Society. Burnout in healthcare has been on the rise over the last several decades, much before even COVID-19 was known as an entity, and was largely due to systemic issues. But with COVID-19, there are also resiliency issues that have become important as well. Burnout can mean a lot of different things to people, but it's often defined as depersonalization, emotional exhaustion, and reduced personal accomplishment in a perceived stressful environment. Recognizing burnout can be difficult, and sometimes we're too busy to ever stop and think about where we fall on the stress curve. So if you look at the figure on the right, with stress levels on the x-axis and performance on the y-axis on the left, their low stress levels and low performance is associated with inactivity. And as stress levels increase, your performance increases. But eventually you get to a tipping point of increasing stress levels where many people are now with COVID-19, which can lead to exhaustion, anxiety, panic, breakdown, and burnout. So there are repercussions of physician burnout, and their personal and professional repercussions. The professional repercussions include decreased quality of care, decreased productivity, and increased physician turnover, which can be quite costly for physicians as well as institutions. There are personal ramifications that also need to be considered, including broken relationships, substance abuse, alcohol abuse, depression, and suicide. Additionally, many of us honor being in the field of medicine, but what we recognize is that almost 60% of physicians now wouldn't recommend a career in medicine to their children with the incidence of burnout. And this is pre-COVID-19 statements, so it can only be much worse at the present time. ACC survey data from 2015 showed that more than 1/4 of US cardiologists and fellows in training were burnt out, and less than 1/4 were not burned out and not highly stressed. So they actually were enjoying their job. So very alarming numbers. What we saw in these pre-COVID data was that the highest level of burnout was amongst mid-career cardiologists and women. But with COVID-19, the increased stress is not only with healthcare workers, but essential workers. Women make up about 53% of essential workers in the US, and women make up nearly 9 out of 10 nurses and nursing assistants, most respiratory therapists, and a majority of pharmacists and pharmacy aides and technicians. In addition, there are also many female physicians that also comprise this essential workforce. More than 2/3 of workers at grocery stores and checkouts, fast food counters are also women, placing women across the globe at the highest risk. And despite these highest percentages among women, women tend to spend the most amount of time directly with sick patients, putting them at an even higher risk of burnout. So the increased burden with lack of knowledge about the virus, lack of resources, concerns of transmission, and lack of adequate treatment, along with ethical issues regarding resource allocation and the fear of the unknown are some of the contributors to increased psychological stress. This is not an issue just of short-term consequences and that it'll go away once the peak resolves. But we need to know that the increased psychological stress that is associated with COVID-19 can lead to increased heart rates, increased blood pressure, endothelial dysfunction, atherosclerosis, which we have seen in other stress-related findings, which all can contribute to long-term development of cardiovascular disease. So COVID-19 is not something that'll be here just with the peak or shortly after the peak, but we'll see many, many more years of damage and many more research articles that are put out there, like Dr. Volgman had mentioned earlier. So as women physicians and nurses, we have much exposure to the sickest, and along with the stresses, we also have other burdens, including household duties. With social distancing, all cooking and cleaning services have limited outside help at this time, and children are at home and some require babysitting needs as well as school needs. So parents are on double duty. They now are taking on teacher roles and have no break when they go home, and some are even separating themselves from their family with social distancing for fear of spreading the virus to their loved ones. This all increases our stress levels. This survey looked at 675 general practitioners in the UK and kind of assessed their stress levels. And they asked them about PPE. And in this survey, about 74% feared for their health or their life. 52% felt unsafe due to the lack of PPE. And only 33% actually felt they had adequate supply of face masks. And 26% have seen patients without personal protective equipment, which is high. And I would say that many people across the globe probably would report even higher numbers in the early days. So switching from the UK data to the US data, among 315,000 people with COVID-19 reported to the CDC during February to April data, you can see that in this figure on the left, these are the cases. In light is the light blue is the non-healthcare personnel, and then the darker blue is the percent of people or number of cases of healthcare personnel. So there's a startlingly high level of healthcare professionals who are developing or obtaining COVID-19. In the 9,000 plus US COVID cases amongst healthcare professionals, the median age was 42, and 73% were female. People reported contact with COVID-19. Majority were in the healthcare setting, but they're also contracting it in the household and in the community settings. Although these numbers of healthcare professionals are high, most of them were not hospitalized. However, severe outcomes, including death, were reported in all ages amongst healthcare professionals. Given the large numbers of women at risk, there's a need for gender analysis into preparedness and response efforts to improve the effectiveness of health interventions and promote gender and health equity goals. For example, during the 2014-2016 West African outbreak of Ebola virus disease, women were more likely to be infected by the virus, but less likely to have power in decision-making around their outbreak, and their needs were largely unmet. For example, resources for reproductive and sexual health during Ebola were diverted to an emergency response, contributing to an ever-rising increase in maternal mortality in a region where one of the highest rates is in the world. And in the US, that's a concern too, because maternal mortality is highest due to cardiovascular disease. And as resources are shifted away from other women's health issues, that can be problematic. So it's important for governments and global health institutions to consider the sex and gender effects of COVID-19 outbreak, both direct gender effects as well as indirect effects, and conduct an analysis of the gendered impacts of the multiple outbreaks, incorporating the voices of women on the front line of the response to COVID-19 and of those most affected by the disease, with preparedness and response policies or practices going forward. So what do healthcare professionals request from their organizations? They have 5 key respects: hear me, protect me, prepare me, support me, and care for me. So 1, hear me. Listen to and act on healthcare professional expert perspectives. This can be accomplished with an array of input and feedback channels, including involving healthcare professionals in decision-making processes. Number 2, protect me. Reduce the risk of healthcare professionals acquiring the infection or being in a portal of transmission to family members. So not only is it including adequate PPE, but access to testing if they're concerned that they may have contracted COVID-19, and necessary accommodations, housing accommodations. 3, prepare me. Provide the training and support that allows the provision of high quality of care. Includes rapid critical knowledge training like ventilator management. And that's why the Pakistan Cardiac Society has formulated webinars like this to help prepare not only the Pakistani people, but globally. As you can see, there's many numbers of people that have joined this chat box across the globe. Number 4, support me. Provide support that acknowledges human limitations in times of extreme work hours and intense exposure to critically ill patients, including the access to healthy meals and hydration. We're hearing from frontline workers that there's not time to eat a meal or to drink water even. And for the fear of self-contaminating themselves while they're trying to take care of their basic needs. Number 5, care for me. Provide holistic support for the individual and their family should the need be for quarantine, including lodging of healthcare professionals if they're concerned that they may have contracted and don't want to spread to their family members, as well as childcare is essential, and the emotional support is highly needed. So what are strategies for clinicians as well? So not only those things that they need to ask their organizations, but these are things of making sure you meet your basic needs, making sure you're taking time out to eat, drink, sleep, and exercise regularly. Taking breaks is essential. Taking breaks from patient care, walking, listening to music, writing a journal, whatever activities inspire you to do more for yourself. Number 3 is stay connected. So give and receive support from your colleagues to avoid isolation, fear, and anxiety. Remember, social distancing does not mean social isolation, and that you can reach out across to friends within your own community and across the globe. And 4 is to respect differences. Recognize and respect the differences in yourself, your patients, and your colleagues, and need to understand where they're coming from. Number 5 is staying updated and using trusted resources of information. Sometimes social media can provide the greatest of information and sometimes the worst of information. So being cognizant of that is important. Number 6, perform self-check-ins. Monitor for yourself for any symptoms is essential. And, you know, one of the things that's out there across the globe is the need to flatten the curve. And many societies have been really good about making a difference in flattening the curves in terms of healthcare and not overburdening the healthcare system. But we also need to know that it's not just flattening the infection curve, but we also need to flatten the mental health curve and making sure that we're doing the primary prevention of taking care of ourselves and those around us in these important needs of time. So I'm pleased to remember that when you used to travel on airplanes, you used to hear the safety announcements before takeoff that in case of an emergency, put your own oxygen mask on before helping others. We would say the same of COVID-19, not only putting on your own PPE mask, but in order to take care of others, we need to remember to take care of ourselves too. And finally, if you feel burned out or highly stressed, do seek attention either from your Institute's Employee Assistance Program, your National Suicide Prevention Line, or your colleagues. Thank you, be safe, and namaste.
Thank you, Dr. Mehta. So I think this talk was very appropriate in the sense because a lot of healthcare professionals these days, especially those who are frontline and treating COVID patients, have experienced some form of a burnout lately. So this talk, I think, has been very useful in that sense. So we would now like to move to our panel of co-chairs. We have some exceptional and accomplished women who are co-chairs for today's webinar. And we would like to ask their expert opinion on some of the questions that we have for them. So first, we would like to go to Dr. Zainab. And we have a question for her. Dr. Zainab?
Yes, Anita, here.
Yes. Okay, so we have a question for you and we would like to hear your expert opinion on this. So are there any gender differences in cardiovascular diseases that may play a role in protecting women from severe COVID-19 infection?
Hunera, thank you for that question. I think a fair bit of that was answered by Annabelle's talk earlier very nicely. But I think I'll repeat a few points because repetition never hurts. So I think, we all know that the case fatality ratios for men are higher, although there are some countries where that is not seen. But there may be several factors that may be at play as to why we see more men dying of COVID than women. And firstly, it has to do with the risk factor prevalence. So men often have a higher prevalence of hypertension, diabetes, and chronic obstructive pulmonary disease, which is associated with more severe COVID and death. And so that is one thing that actually works against men and more along being protective for women. Secondly, estrogen is thought to be a protective hormone. There's some mice model data from the SARS-CoV virus times that suggests that when male mice were infected with SARS-CoV, they had gonadectomy, but there was no difference in outcomes for the SARS-CoV or COVID infection. But when female mice underwent oophorectomy, they found that they had more severe disease and died from that disease, which suggests that there is some effect of hormones as far as severe COVID infection is concerned. And that's something that's under investigation in trials right now. And thirdly, this is something that Annabelle mentioned in her talk too. It has to do with the immune response. So women, we know, have stronger and more adaptive immune responses than men. So they're able to get a hold of the virus, get rid of the virus much quicker. In immunization studies, we know that they mount a more stronger immune response. And just because of the fact that they're able to get pregnant, there is the adaptive immunity aspect of it that must be considered, which we find, that in COVID, there's most of the severe COVID infection has to do with an immune response that's going haywire towards the later phases, later days. So that's something, these are the three things that might be protective for women. Now, in situations where we're seeing the case fatality ratio being almost equivalent, it may really have to do with societies or countries where women's healthcare seeking behavior and the access to care may be different than it is for men. And that we know for several other diseases, especially in the countries that Annabelle mentioned, both in India and Pakistan, the healthcare seeking behavior and access for women is very different. So that's something that I think probably plays a role as far as case fatality ratios is concerned.
Thank you, Dr. Samad. That was an exceptional answer. So would you think that this access to healthcare might influence the numbers of women that are getting diagnosed with COVID-19?
Most likely, yes. I think the infection rates has been associated with gender, knowing that occupational exposure might put more men at risk. But then again, household clustering, where you would expect that transmission would still happen to the female household members. But then men get tested and diagnosed more. So I think that is definitely at play. And unless we do studies, rigorous studies looking at prevalence of this disease, we're not really going to get at the root, the true picture as far as gender difference is concerned.
Okay, thank you so much for this answer. We would now like to move to Dr. Amber Malik. Dr. Amber, are you with us?
Yes.
Okay, so my question to you is what impact this COVID-19 lockdown might have had on women seeking healthcare for urgent cardiac issues? Do you think they're more prone to having complications if they're not having access to healthcare these days?
Thank you for your question. First of all, I'd like to congratulate all the three speakers for an excellent collection of talks, and I think very relevant. I learned a lot, and we put it together. A lot of things that are going on in everybody's head, reading, and this is all that we do these days, talk about read up on it. So it's very nice to think perspective and look at it from the women's point of view. I think the question is essentially what's happening in the lockdown with women in healthcare. And let me talk about it from a Pakistani perspective, that we are now in the second month, at the end of the second month of our lockdown, essentially. So, you know, people have been sitting at home since March. And I think what is happening in the rest of the world as well as in Pakistan is that everybody's getting fed up. We've talked about mental issues, and I can see that happening around us. But what we noticed in our hospitals, at least particularly for Lahore, let me tell you, that as we went on to build 1,000-bedded expo center for infectious diseases and to quarantine and isolate and put up COVID patients, what we got here was that a lot of our hospitals actually became empty, and all our clinics, people just didn't show up. And I can tell you about cardiovascular disease, our ERs, we were not receiving the number of STEMI that we were expecting, and that we get all the time. And I don't know about Zainab in Karachi and everyone, but we did hear that, and if you ask from other people, interventional labs, their work went down by 1/3, essentially. And our clinics, they're just empty. We did stop doing any kind of elective patients even. So the message went across to patients that they're not welcome maybe, and they themselves were afraid. And again, there's the stigma, the fear of coming to hospital or going to doctors that you will get the disease. So people hide their disease. So who is the person who bears the brunt of it most of all? It is women, particularly in our country, because they play down their problems. Other people have bigger problems than them, and so the gender comes in over there. And so I think that's what has happened. And there are a lot of articles now that what happened to all the cardiac patients in the epidemic. And it seems that either they have stayed at home, because it's not possible that they are not getting sick, but either they've stayed at home and they have suffered the disease and they will come back to us. Now they are stacking up somewhere and they will start coming back in. Also, there's Ramzan going on at the moment here also. So that's when things go down as well. What I do have, a lot of patients are looking for help. A lot of them are getting their hypertension out of control because they haven't seen anybody for the last 2 months, particularly women, some women living alone, and even women who are living with people because they don't know what to do, where to go. A lot of their doctors are not in contact, are not in touch. So there's a lot of chaos and a lot of worries about patients. They want to see doctors physically, but they're afraid to go and meet them. So I think it has made a lot of impact, and we will see the fallout very soon when things become a little bit more streamlined. We are encouraging people to come on telemed. That has to be with people who are more tech savvy, and people are tech savvy, but it will take a while for them to catch on that they can have access to healthcare even without having physical contact, which is the stigma as well as the fear factor that is causing them problems. So I think a lot of hypertension is out of control amongst women hanging around over there, and the routine work and the routine problems like heart failure, acute coronary syndromes, they're suppressed somehow or the other, and somewhere they're hidden, and I'm sure they're going to crop up pretty soon.
Yes, absolutely. Thank you, Dr. Amber. It's definitely the same over here in Karachi as well. We have also seen a drop in the volume of our STEMI patients, but slowly it's picking up. But yes, your answer was very relevant, and thank you so much.
Thank you.
So next, I would like to invite Dr. Khalda Sumro. So we have a question for her. Dr. Khalda, are you with us?
Yes, Dr. Alda, I have unmuted you.
Dr.
Can you hear
Khalda?
me? Can you hear me?
Yes.
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 Okay,
I want
Dr.
to say,
Khalda?
I want to say thanks to my foreign speakers who spend their time to be with us on this occasion, and they, this is their uh, I mean, this is their time which matters for us. Regarding your question,
Yes.
you asking?
Yes. So the question we have for you is, we know that cardiovascular disease is fairly prevalent among pregnant women in Pakistan, and it is the leading cause of death in pregnant women amongst the pregnant women in the United States. So is there a need for any specific guidelines in the management of pregnant patients who have COVID-19 infection in terms of risk mitigation for cardiac injury?
You see, if we are talking about the pregnant ladies in younger age group, especially when women are in the productive age, they are more younger than the 50 years of age. We know that the risk increases after the age of 50. Up to 50 years, 2.4. 2.4 is the risk for mortality in women and men. So our pregnant women are comparatively younger than that age group, and they have the same risk of non-pregnant women. And if we are talking about the comorbid conditions, congenital heart diseases, ischemic heart diseases can be present in these patients along with the diabetes. So in that case, mortality usually increase more than their same age group. And we have to be careful and for that group. If we are talking about the first trimester, you see, there is usually flu-like symptoms and mild symptoms in these patients if they don't have any comorbid conditions. And these patients usually can be followed and can be isolated at home with the medical advice taken from their GPs and consultants. Later on, if after the age of after 32 weeks of the pregnancy, risk increases in these patients because of the volume overload, infections, and lot of other things. So there are more chances of complications in that group. And as far as baby is concerned, in early first trimester, early abortions, ectopic pregnancies, and other infectious diseases can lead to the problem and the premature baby. But in the late, after 32 weeks of the pregnancy, usually these patients have certainly can be isolated and can be having other prevention measures which are common for the other other people. Guidelines are the same up till the pregnancy or delivery time. So that period, our patients can have the same guidelines, can follow the same guidelines, but they can limit their meeting with the doctors, and that is important thing, because to go to hospital will be dangerous for them. And as far as the risk during the pregnancy is concerned, baby will not have infected from the coronavirus by vaginal delivery. You see, by vaginal delivery, baby will not be infected. Even after the delivery, baby will have safe breastfeeding from the mother. there is no impact on the breastfeeding. So if we think about the guidelines, yes, in the third trimester, but almost they are same if we are considering the C-section. These are same for the elective. These are same for the elective surgery. Yes, delivery. As I have already told that vaginal delivery can be performed. Premature delivery before the C-section before the time, even in certain those conditions in which there is mother will have relief from the symptoms and baby will be safely delivered, that will be indication for the C-section in the last term of the pregnancy. Anyways, guidelines mostly depends upon as other women suffering from the coronavirus and elective surgery. So there may be a need, but the mortality is mostly due to the comorbid conditions. Increased comorbid conditions and congenital heart diseases.
Okay, thank you, Dr. Khalda.
Hmm.
So next, we would like to ask Dr. Nusrat Majid.
ये तो उसको बोलो कि वो
Dr. Nusrat Majid.
Is it okay?
Dr. Nusrat, can you? Yes. Okay. So, Assalamualaikum. Dr. Nusrat, I have a question. We know that the quarantine and the lockdown have a lot of psychological effects on the people. What mental health tips would you give, especially to women with cardiovascular disease, to counter this psychological impact? And do you think women in cardiology can maybe partner with psychologists and psychiatrists and in this new health order to help this mental health issue?
Yeah, thank you. As you can see, I'm half asleep. But anyway, it was an important issue and I decided to participate, and thank you so much for invitation. So, Bismillahir-Rahmanir-Rahim, in the name of God, the most merciful. Today, my Lord, we pray for a miraculous healing and an end to this COVID curse that has fallen upon us. Amen. As we know, we never heard this word lockup, curfew, and quarantine till 5th August 2019. And my heart bleeds to speak about it when the greatest human calamity was imposed on the people of Kashmir, especially women and children. I would leave it here, but it's very sad that the entire world kept quiet, and then there was divine justice and God said, okay, let me put the entire world in lockdown. So coming back to your question about the negative psychological impact, I think besides negative, it has a positive psychological impact. Also, maybe you don't have time, that look at the ozone layer, it is clearing up and people are spending more time with their loved ones, their children, parents, they have time for self-reflection and connection to God and all those positive things. Regarding tips for mental health, a lot has been said, but I would just like to enumerate a few things. Number one, it is very important to have a routine. It doesn't mean that if you are not going to work, you should behave like an animal, get up whenever you want to, eat whatever you feel like. No, the life has to be disciplined. This is the basic characteristics of human beings. Then you've heard, and I think people should stay away from screen and social media. If you are glued to TV and social media, this definitely is going to have negative impact and you may not be very comfortable. Yes, once in a while, not once in a while, twice, thrice, it is very important to be aware of what is going on, and especially on TV and some of the social media, you are getting some useful tips regarding prevention and how to keep ourselves safe from this deadly infection. Then you've heard about people talking of role of diet and exercise, role of vitamin C, D, etc., minerals and all that. People are talking about yoga and meditation. And here I will go back to the basics. 1400 years ago, when we were asked to pray 5 times a day, and especially in this holy month of Ramadan, maybe we are praying 7, 8, 10 times a day. And can you see the beauty? Just by praying, we combine all 3 in that. We are exercising. This is an excellent form of exercising different parts of the body. And yoga, again, when we offer our prayers, we have to be in different poses. We bend, we bow, and all that. And third, meditation, because we are standing in front of God and we have to be fully attentive. And then we get rid of all the worries and other nasty things around us. So this was diet and that. And then you also remember that 1400 years ago, the Prophet Muhammad, peace be upon him, said that in case of epidemic, don't go to that place, nor do you leave that. And this perhaps is the modern version of your lockdown phenomenon. So then I will not, the speakers have very nicely elaborated upon prevention against a psychological impact. I would like to touch upon a different aspect of that. Regarding diet, you talk about vegetable, fruits, and all that. Remember, in the Holy Book, 3 things have been mentioned, and that is not without any significance. Number 1, your dates, olives, and figs. And then lately, people are talking a lot about black seed, kalonji in our language, Nigeria, I don't know what many medicines are being, this is the potent anti-inflammatory and antioxidant. And lately, a herb which is called sumac. I wonder if any one of you is aware of that. It spells like S-U-M-A-C. These are small dried berries, and believe me, they have a miraculous effect. I have given it to some of my patients, again, elderly ladies with heart disease, and then the complaints of palpitation and fainting and all that. Most of the time they were on telephone with me and they are doing wonderfully well. And then honey, of course, you know, it has medicinal properties, figs, and then a very important thing, and which has worked wonders, at night, if you instill 1 or 2 drops of extra virgin olive oil in both the nostrils, you try that. At the moment it gets down to the throat, you have a very nice plus little unpleasant type of feeling, and you get to know that something has entered into your system and it is about to act. So these were the little things that and then then you have to be, you have to keep yourself happy. I found one activity, that is open your old albums. You really feel happy, the time passes quickly, and then one keeps wondering, oh, a few years ago in medical school, we were like this, and that. Now coming to the third part of your question, that collaboration of cardiologists and psychologists, I've been a firm believer that. Before I go to that, I would like to add the last point, that it should be your firm faith in God that is going to pull you through this crisis. And remembering my days at Rawalpindi Medical College, where I established the Department of Cardiology, I always worked in close liaison with the Department of Psychiatry, and especially for women, you know, this problem of palpitation, heart sinking, and all that. Very often these women were labeled as functional, or, you know, they are supracortical, they are pretending. They would go to psychiatry ward, then the professor would decide to give them a shock, and before, oh, send them to Professor Nusrat, because before shock therapy, you need to evaluate cardiovascular system, and then I would do an ECG and echo. And this is how, you know, for the first time, I started talking about ischemic heart in younger women also. So I think it is very important, because body and soul, mind and heart, they work side by side. And I think the lady cardiologists have a great role, not only to solve the psychological problems of women patients, but also men. Thank you.
Thank you, Dr. Nusrat. We have a question for Dr. Amber Ashraf.
ठीक हो गया काश?
Dr. Amber?
Yes, I'm around.
Yes, Namika. So the question we have for you is again related to this lockdown. How can physical activity be maintained during this lockdown to achieve a better cardiovascular risk factor profile for primary prevention and secondary prevention for anyone who has cardiovascular disease, especially women?
Thank you very much for asking me a question during these days of lockdown. Before answering it, I really want to thank Dr. Khalda Sumro, Professor Haroon, Dr. Ishtiaq, and organizing such a nice webinar on cardiovascular diseases, COVID-19, especially in women's. And really thankful for the guest speakers as well as a very nice answers from all of you, especially Professor Nusrat, Dr. Khalda, and Amber Malik. They have highlighted so many things in very nice way. It's really a very interesting topic, how one can maintain a physical activity during this era of lockdown, and lockdown. So as we all know, the cardiovascular modifiable risk factors, they can be controlled with a lifestyle modification. And the main pillar is a physical activity. At least a 30-minute of physical activity for 5 days a week is the foundation. And with the help of this, we can modify the cardiovascular risk factors. How one can achieve this activity during these days? So we must have to set and define some goals. We must have our daily routines, as Dr. Nusrat highlighted it, discipline ourselves, set some timetables, as well as to make a to-do lists. Meanwhile, planning for daily exercises. Everybody is saying it's a lockdown where we should go and do an exercise. We can do inside as well as outdoor exercises. Inside exercises, as we all know, the skipping, the yoga, aerobic exercises, especially for the females, those who practice to do it, well and good. If not, they start trying it. Outside exercises, we can do it if we have a lot of space at our home. If not, we can go outside in the park, but what is important to wear a proper mask as well as to keep a social distance. That is very important, with the help of which we can have our daily physical activities, at least 30 minutes spare for ourselves in order to prevent the further disease progression. So in this way, we can look after our healthy lifestyle and health. While as a female, we are doing our everyday household activities, we can organize it in such a way that we can involve physical activities more. Like, just see a simple TV remote. It's better to go and switch on and off the TV by yourself. Use these gadgets in physical ways so that you can improve your physical activities. Along with this, you can define new hobbies for yourself, just like a gardening. You can have cooking, any other music, dancing, swimming, anything which you can, especially while you define new activities, hobbies during these days, it will help not only your physical health as well as it can relax you. It can relieve your stresses. Like if simply you are doing a gardening, you can do a physical activity. With the help of this, you can modify your life and look after the risk factors as well. Meanwhile, eat healthy, drink plenty of water, do a regular exercise. And the good thing is Ramadan. In this Ramadan, we can make more time for our Allah subhanahu wa ta'ala, and we offer our prayers and 20 Taraweeh. We can do a very nice physical activity during this time. So we can spend the time with our family members, make them happy, along with combined physical activities, combined exercises. This is an opportunity. We should take this opportunity in such a nice way we smile just like Hanana is smiling, and it can give a nice, healthy, relaxed environment, and we can help our elderlies, the sick and alone, and we can motivate them to come and do a physical activities and exercises in this way. All the modifiable risk factors like diabetes, hypertension, obesity, everything we can look after, because physical inactivity is just like smoking. So the best thing is we should motivate ourselves, all of us, and we do these exercises, and we can utilize our knowledge and skills not only to improve our mental health, physical health, as well as we can put energy to our family members. They should do the physical activities, the friends, and we look after our patients and guide them as well. Thank you very much, Anana, for asking this question, and wonderful type of the answers were already given by all the senior professors and the faculty. Thank you very much.
Thank you, Dr. Amber, and thank you to all our exceptional co-chairs. We would now like to move on to the questions from the audience, and Dr. Sanam Faja would moderate that. So thank you, everyone.
Thank you, everyone. Am I audible and clear?
Yes, and Dr. Sanam, very loud and clear.
All right. Thank you very much, Basit, for a prompt comment. And it was really an excellent session. Before going and moving to the question answer session, I would like to answer one query which was raised by Dr. Amber Malik. Dr. Amber, I have been working in NICVD in the ER, and NICVD is the leading tertiary care hospital for the cardiac facilities and especially intervention, and we have been doing the highest number of primary PCIs. So in this COVID pandemic, what we have noticed from our data that around 40% decline in the primary PCIs. So you were very right that about 1/3 decline in the primary PCIs in general. So now we move to the questions from the audience. We have Dr. Salit Fatmi with us, and he would like to ask a question from our speakers. So I would, do we have Dr. Salit Fatmi?
Dr. Sanam,
Basit, can you help me?
He has asked the question in the chat, so maybe we can read it out.
All right, if he's around, I would like that he can ask by himself or I can ask on his behalf. All right, so let me ask the question. Dr. Salat has asked the question that, as we know that we have the patient who already have been went for the cabbage in the past, and because of this COVID-19, they are on risk of having the thrombosis. So what do you think that should we keep those patients on the DAPT until this pandemic is over?
We can't hear.
Who would you like to answer that question?
Annabelle, why don't you take a stab at it?
Okay, thank you so much. So the answer to that question is unknown because there aren't any studies. So I think that people will have to just take their use their own clinical judgment. We know that there is a higher risk of thromboembolic disease in COVID-19. So if patients have COVID-19 and they had a recent stent or they had a recent MI, I think that People will just have to treat individual patients with their clinical judgment. I know that my colleagues at Rush have been struggling with all the venothrombotic embolic disease that they're seeing in the cardiac patients, and some of them are being put on anticoagulants in addition to the dual antiplatelet drugs. So I think that people will have to just use their own judgment until we have more answers. I hope that helps. Maybe Dr. Mehta has another suggestion also.
All right. Thank you very much, Dr. Nappi. And the next question was from the audience, was about the anti-malarials. And there was a question on the chat box that they were asking that, what about anti-malarials? Because we have a contradictory data. Some are supporting for prophylactic use and for treatment, whereas some other data is declining about the use of it. What do you think that the data we have till now, what would be our strategy for the use of anti-malarials in this pandemic of the COVID-19?
I can take a stab at that. So actually, there is no robust evidence for the use of chloroquine or hydroxychloroquine for prophylaxis. So if it is taken, it's best to be taken in the framework of a trial, so you can contribute to development of more evidence in that area. But as such, there's no concrete, robust evidence for the use of these agents for prophylaxis.
All right. Thank you very much, Dr. Nappi. We have Dr. Suhail Khan with us, and he would like to ask his question. I request Basit if he can unmute him so he can ask the question for me.
Yes, Dr. Suhail, you can speak.
Can you guys hear me?
Yes.
Yeah, this is Dr. Suhail. I'm based in Salt Lake City, Utah. It's a great conference. Thank you, Dr. Shahab and the team for putting this together. I'm just going to piggyback on what Dr. Samad was saying earlier. And just an example, I had a patient a week ago. One of my physician friend, his mom, she was 82-year-old, and she started having severe headache in the morning, called the EMS 911. They came in and they're like, well, you are 82 years old, you have some headache, and there's this COVID thing going on, so why don't you stay at home and rest a little bit? And then I was called about 6 hours later. I talked to her on the telly, and turned out she had a huge stroke and intracranial bleed. So we are already seeing this downward trend in acute MIs and stroke. And I'm really worried when the second wave hit. Without vaccination, I'm worried once the winter or the fall come across, we will see a large trend of that. Is the AHA doing anything in terms of public awareness, how to address this issue? Because COVID-19 at worst, for example, if you look at the Italian data, at worst the mortality is about 4 to 5%, or maybe it's 1 to 2% in the US or other countries. But if you have a major MI, the mortality can be as high as 100%. And we already know that women may not present with typical symptoms. They tend to stay home. So what is AHA doing in terms of addressing that issue? And the second question would be about the big elephant in the room that we never talk about is the social determinants of health. And now we are seeing in the US that the COVID-19 is affecting minorities, African-American and Latino. There's a very high mortality in that group. And then, I hate to say that, but I also take women and then that minority because of the access to care and the atypical presentation of cardiovascular disease. And I'm just curious that whether that's something that the AHA is looking at to address the issue. Thank you.
Thank you. This is Dr. Volgman. I'll take a stab at that comment. So on behalf of the American Heart Association, which Dr. Laxmi, Mehta, and I are representing, the AHA, the American Heart Association, has actually put out some public service announcements speaking about going to the calling 911 if you're having a stroke or a heart attack. As I showed in my slides, that's one of the public service announcements that they're doing. Of course, we need to do more. Our hospitals and our local governments need to also do more to take out the fear of people to call 911, which they have done. It's you know, everyone has to join in the efforts. It's not going to be just the American Heart Association, but everyone needs to inform their patients not to worry about contracting COVID when they're having a heart attack or stroke, because that's what's going to kill them more than the COVID. The other thing that you alluded to is the racial and ethnic minority having more infections and mortality from this. And of course, we're all very concerned about that. The AHA has actually given a request for proposals for research studies, and they have just granted $2.5 million. And most of the studies that were funded touch upon the racial differences, the ethnic differences in the mortality in this disease. So the AHA, of course, is doing their part, but I think we all should be doing our part in making sure that we inform our patients about the importance of social distancing and the things that we are being told to do. Unfortunately, people who in certain socioeconomic status can't do social distancing as well as some more affluent people can. So, you know, I think the public health officials have to address those issues. So I hope that answers your question.
Additionally, the AHA on their website has lots of information both for patients, so the lay community, as well as professionals. We've released a podcast series for patients to listen to, especially we've done one on women and heart disease, one on pregnancy and COVID-19 as well. So those resources are available out there for the patients as well as professionals. And the research definitely is there, and so you can go onto the website and learn more about all of those.
So just a quick question, Dr. Laxmi, if you can please answer so we can move to close this session of question answer. Iban Awan just want to ask that what do you think about the ARBs and AC inhibitors? Should we stop them, and what is the data?
Lakshmi, do you want me to answer this since I presented the data on this?
Sure, you can.
I'm sure you have your opinions as well, but the data has actually shown that well, first of all, I want to make sure that everyone knows that all of the cardiac societies in the United States as well as Europe have recommended not stopping the ACE inhibitors and ARBs. And it is proving to be beneficial in some patients. That was shown in the China study. The New York study did not show mortality benefit, and the meta-analysis studies have not shown mortality benefit, but it is very important for us to advise our patients not to stop their ACE inhibitors or ARBs or other RAS medications for fear of getting worse outcomes. But the data needs to be completed, but the societies have been recommending not to stop those ARBs and ACE inhibitors. Thank you.
All right, we have Dr. Usha with us. Dr. Usha wanted to ask a question from you, Dr. Annabelle. And if Dr. Usha, you can, Basit, can you unmute Dr. Usha?
Hi, Annabelle. Hi, everyone.
Hi, hello, Dr.
Yeah, thank you for taking my question. Two things. One is an observation. This is what Annabelle had talked about, the male-female ratio in Pakistan. So what we're seeing in India is across the country, more men are infected than women, more men are dying than women. But just yesterday, there was a report saying that inner city women, especially the urban poor women, seem to be having a higher mortality as well, which may circle back to the whole social determinants of health issue that was brought up. So that is just an observation. My question is to Annabelle. Has she seen any difference in women who take hormone replacement therapy in terms of outcomes of COVID-19? And also, the postmenopausal versus premenopausal women.
Thank you so much, Usha. It's great to see you all the way from India. So I actually, we are also seeing in the urban Chicago area the same thing, that the urban women of Chicago are not having less mortality. So our data is still being compiled and being analyzed, but we are about to publish something about that. So very interesting observations from India. In terms of hormone replacement therapy, it's a great question, and I'm sure you know the answer to that. We don't have enough data. We don't have any data, actually, but I think that's a great question, and that's something that maybe we should look into, and maybe we could do a registry for women who have COVID. And the American Heart Association is actually doing a registry for COVID-19 patients, and that would be a great question to ask that registry. Thank you for that question.
All right, thank you, Dr. Nabi. Last question from Dr. Harun Baba, and then we will be moving to close the session and with a vote of thanks. So do we have Dr. Harun Baba with us? We would just move to ask the question.
Thank you for giving me the opportunity to speak and make a few comments. What we are seeing, this COVID crisis, is the time has passed, is around more than 6 months since we are in this COVID-19 that women with acute coronary syndrome or an MI, they are more vulnerable and the prognosis is more poor than as compared to their male colleagues. So what I want to say is that we should be more prepared now, since 6 months have passed, rather than being afraid of this COVID-19. Of course, we have to take all the precautions with PPEs. All our centers should be prepared to deal and take up primary PCIs as well as other emergency measures when the patient comes to you or to the hospital or to the emergency with ACS. So I would like to ask that, has the world of cardiology in the West or even in the East, have they done some concrete steps in this way, in this path, or still we are struggling to create a better platform?
Dr. Laxmi?
Yeah, I mean, if the question is pertaining to the care of COVID-19 patients in the last 6 months, I would say, every country is going through it at different rates, and every country is so different in the types of patients that are acquiring it, as Dr. Volgman had shown previously on her slide. So I think that, yes, 6 months has gone and we've learned a lot, but there's so much more to learn in terms of the treatment of these patients. And that's where partnerships with societies like the American Heart Association, Pakistan Cardiac Society, to cross-collaborate across the globe so we can get a better understanding. Yes, there's fears, but many of those fears is also based on the media and the lack of PPE. So as societal organizations, we're working to, pass out the public service announcements, and which we're happy to share the AHA's public service announcements also with the Pakistan Cardiac Society. But it's important to share the messages with the community so that people are aware and people to
Would you
need to
like to make any
understand.
comment on this?
I'm sorry?
Thank you, Dr. Laxmi.
Thank you.
Dr. Anita, would you like to put any comments on it?
Dr. Anita, please unmute yourself.
Yeah.
Yes.
Yeah. Just want to add that it's great that we are seeing the falling number in some countries and even in the admission that we had in Iran. So some good points we are seeing, although many things still is unknown. But however, we are seeing the falling in number of cases that are admitted in the hospitals, even maybe to 1/3. However, the second wave, we are worried about that. But the good point is now we are seeing the falling numbers. And again, the semi-elective cases are going to be admitted. So something is we can see in China and Iran, and even in some places in the US, there are falling a number of the cases, but it depends on the countries and the locations.
Thank you, Dr. Anita. And we would now compile this question and answer session. I just would like to make a final comment that a woman is very important part of the society. And it is said that if you educate a woman, you educate the society. So why we this forum on this forum, especially from the Durat Women Forum, why it's important to educate the women about the prevention, about the impact of this COVID-19 on the cardiovascular and the psychological illness. Why it's important? Because if you educate the women, you will educate the society and the generation. So I wish and I hope that all the women and all the males who are here with us today should at least educate whatever we have learned today, at least 10%. So if we are 300 or 400 people over here and you give the message to 10 people, so we can understand how much we have communicated and get out of today's meeting. Thank you very much, everyone, for your valuable time. And thank you very much to all the speakers, Dr. Anita, Dr. Laxmi, and Dr. Annabelle. For the vote of thanks, I would like to call upon CEO, the Ferosan Pharmaceutical, to come upon and pay the vote of thanks to our honorable speakers and our chairs and co-chairs.
Thank you very much, Dr. Sanam. This is Osman Wahid. I'm the CEO of Ferosans. It's a unique privilege for us to be sponsoring, supporting this really high-powered session of extremely competent female cardiologists. As we have seen in this COVID crisis, women leaders across the world have really shown the rest of the planet how these crises have to be managed. And we salute all of you in the front lines who risk your lives, yourselves, every day to support your patients in this incredible time of need, facing a terrible pandemic. I'd like to especially thank our three speakers for today, Dr. Annabelle, Dr. Anita, Dr. Laxmi Mehta, of course, the co-chairs of this evening, Professor Khalda Sumro, Dr. Sania Nishtar, who because of some technical issues, unfortunately, was not able to join on, Professor Zainab Samad, Professor Amber Ashraf, Professor Amber Malik, and Professor Nusrat Ara Majid. And of course, the moderator, Dr. Hunaina Shahab, and Dr. Sanam Khwaja. Thank you all so very much. We pledge to support you in this time of need in any way we can. And we hope that together we can overcome this pandemic. Thank you very much.
Thank you all. Thank you. Have a very nice day, and we wish very healthy and safe lives for everyone. Thank you once again. Good night.
Thank you.
Thank you all. Bye-bye. Thanks.
Thank you. Allah Hafiz. Goodbye, everyone.
Thank you.
Goodbye, everyone. Allah Hafiz.